Hello, and welcome to Talking About Tumors with Ryan and Ryan. Just Ryan Holstead today, coming back after a long hiatus for a short discussion on a drug that was recently presented at ASCO conference for metastatic pancreatic adenocarcinoma. Ryan and I will be back soon to continue our discussions on broader topics. However, this new drug for pancreatic adenocarcinoma is of interest to me, as pancreas cancer is one of the areas I specialize in. I also think that this is an interesting new mechanism of action that will likely impact other tumor sites as well. So I wanted to go into it a little bit today, as it will be still a little while before we have a chance to go back through and update many of our discussions that are going to become outdated as the months and years goes on. So jumping into it, we're going to be talking today about the drug Daroxonrasib. This is a KRAS on inhibitor. Just as a bit of a background and a warning, we will talk a little bit about biochemistry here today, is that the RAS protein is the RAS sarcoma virus. This is a GTP-based kinase that's found endogenously in most cells in the body and is often found as a mutation in many cancers, most commonly being either a KRAS mutation or an NRAS mutation. If you recall, RAS sits in the prototypical pathway, generally represented as EGFR, RAS, RAF, MEK, and Eur. In the case of pancreas cancer, this is actually found in 90% of all of pancreatic adenocarcinoma. It's also an early driver mutation, and when we look at animal models such as mice, we often find the KRAS mutation being one of the first mutations noted when a precancerous lesion such as a cyst transforms into a malignant process. RAS exists in two states, either an off or on state, and this is based upon whether or not it has a GDP as in dog, or a GTP bound to it, with the GTP being the on state. There's been a lot of interest for many years to target this protein, as being so commonly found in many cancers has been a great interest of drug development. However, up until very recently, this was thought to be an undruggable protein, primarily because it has no typical binding site. So we often think about drug design. Often there's a ligand that binds to a protein or enzyme, and that binds into a binding pocket. And that binding pocket is often a good place to target drugs. However, this protein does not have a typical binding pocket, and the pockets that were found over the years were thought to be generally shallow, making it hard to develop an antibody or a small molecule to capitalize on this. For practical purposes, it's best to think of the RAS protein as a smooth ball. Over the past 5 years, we have had at least one specific mutation KRAS that we could target, and this is in the G12C. Once again, remembering back to our biochemistry days, C is a cysteine amino acid. And a cysteine amino acid has a sulfur on it. Sulfurs are capable of developing covalent bonds to other sulfur moieties, disulfide bonds, and drugs were developed to capitalize on this, namely sotorasib and adagrasib, that have been studied in both lung cancer as well as colon cancer, with approvals in both of those locations in the US. These drugs only work in KRAS G12C mutations, and their benefit, although real, does appear to be somewhat modest. In the case of non-small cell lung cancer, if you recall, it improves the progression-free survival by about a month, from 4.5 months with standard of care chemo to 5.5 months with the sotorasib or adagrasib. And similar small benefits we're seeing in colon cancer with a combination with an EGFR inhibitor compared to chemotherapy, improving progression-free survival by 3.5 months. In the case of pancreas cancer, the G12C mutation is only seen in about 1 to 2% of the patients, with the vast majority having other changes in the G12, such as G12D or G12V. Also, not uncommonly, pancreas cancer will harbor other KRAS mutations, such as Q61. Medications such as sotorasib and adagrasib bind to the mutated G12 moiety when the protein is in its off state, namely when it's bound to GDP. This keeps it in the off state, leading to protein degradation and apoptosis. Daroxonrasib, which we're going to talk about now, is an on inhibitor, and this was designed a bit differently. Because it can't bind directly to KRAS, the drug was developed to bind to a chaperone protein known as cyclophilin A. Cyclophilin A generally doesn't have a direct interaction with KRAS, but when this drug binds to it, it actually causes a structural change in cyclophilin A that makes it bind tightly to a RAS protein when it's in its on state, making a tri-complex with RAS on, cyclophilin A, and Daroxonrasib. Because the drug is binding to a protein other than RAS, and because it generally interacts with any RAS in the on state, early phase studies had shown that binding possibilities were independent on the specific RAS mutation. A phase 1 and phase 2 clinical trial was published earlier this year and showed an objective response rate of about 35%. And given these positive early studies, phase 3 studies had been designed, and at least one is now reported out. The specific trial was named RASolute, RASOLUTE 302, and is published in the New England Journal on May 31, 2026. This was a randomized controlled trial. It was open label, which means that the intervention control arm knew which arm they were on, and was studied in the second line. They include any patients who had progressed on a prior line of chemotherapy, whether that was modified FOLFIRINOX, gemcitabine and nab-paclitaxel, or some other 5-fluorouracil or gemcitabine-containing regimen. They included patients who had prior neoadjuvant or adjuvant curative intent treatment, as long as progression had occurred within 6 months of their last cycle of chemotherapy. The study used patients with good functional status with ECOG 0 to 1, excluded CNS metastases or prior RAS-directed therapy. The inclusion criteria was not specific to G12 mutations or RAS mutations for that matter, and they include all comers. It's worth noting, however, that the non-RAS mutated patients will make a minority of the population. They randomized the groups 1-to-1, stratified by presence of a G12D or V as in Victor mutation. Second stratification were any G12 mutations or other RAS mutations such as Q61 or G13. And finally, for patients without a RAS mutation. Patients randomized 1-to-1 to either Daroxonrasib or chemotherapy. Control arm were allowed to receive any standard chemotherapy arm. These included our general approach to second line, such as gemcitabine and nab-paclitaxel, FOLFIRI, FOLFOX, modified FOLFIRINOX, or nanoliposomal irinotecan, and fluorouracil. 248 patients were randomized to Daroxonrasib, and 252 were randomized to chemotherapy. Primary endpoints for the study were overall survival in the RAS mutations harboring a G12 and the patients harboring a G12 RAS mutation, with secondary endpoints including overall survival and progression-free survival for non-G12 mutations and all comers. The primary endpoint was split with the overall survival and progression-free survival, with the majority of alpha relegated to overall survival at 4.8%, and 0.2% relegated to progression-free survival. Secondary endpoints also included quality of life analysis. Of the 500 patients enrolled and randomized, 29 in the control arm, which made up about 11.5%, did withdraw, likely because of disappointment of being in the control arm. In addition, as I mentioned, a majority of patients were with G12 mutations, and there's only 20 non-G12 mutations in either arm. The age of the patients was representative, with ranging from the age of 30 to 88. And the prior chemotherapy seemed like what we generally would see in practice, with 40% of the patients receiving modified FOLFIRINOX, 37% receiving gemcitabine and nab-paclitaxel, and a third of the patients had had a prior pancreatectomy. At a median of 8.5 months follow-up, the study did meet its primary endpoint, with a significant improvement in median overall survival of 13.2 months versus 6.6 months. This translated into a hazard ratio of 0.4, which was statistically significant. When we looked at the patients without a G12 mutation, we saw similar outcomes, but once again, it's worth keeping in mind that they made a minority, so this finding was heavily weighted towards G12 mutations. At 1 year, 53% of patients on Daroxonrasib arm remained alive versus 18% in chemotherapy. When we looked at progression-free survival in the G12 mutations, we saw also significant improvement at 7.3 versus 3.5 months with a hazard ratio of 0.4. At 6 months, progression-free survival was 58.7 versus 31.7%, favoring Daroxonrasib, and it did appear as we approach a year that quite a few patients on the Daroxonrasib arm had begun to progress, although approximately a third continued to be progression-free, keeping in mind that this is still an early interim analysis. So the drug is effective, but at what cost? Now, this is a pill that's taken once a day, and it does demonstrate a pretty high rate of toxicities, which seem to be mostly what we would call on-target, off-tumor, or basically inhibiting the RAS protein in areas that do not harbor pancreas cancer. These included a rash, which was seen in 86% of the patients, 13% of which were graded as 3 or higher. Diarrhea in 67% of patients, 5% at grade 3 or higher. Stomatitis was seen in about half the patients, just over 10% were grade 3 or higher. And 40% of patients had outright vomiting reported. 43% overall patients experienced a grade 3 or higher toxicity, which is rather high. And at least one patient died from a side effect of this drug with pneumonitis. In the supplemental, the authors do provide some potential treatments to help prevent the rash, stomatitis, and diarrhea, and these are not completely novel interventions. Include things such as doxycycline and topical steroids, which we often use for patients receiving anti-EGFR therapy such as panitumumab or cetuximab, and consideration of oral steroid mouth rinse, which we've used in other drugs such as everolimus. So the bottom line is, and why I'm excited to talk about this drug today, is that this is a big step forward. We have a median survival beyond a year in second-line patients with pancreas cancer. Of course, one of the limitations always when we are looking at other trials is whether or not these patients are representative or highly selected. However, the control arm overall survival seemed pretty similar to what we would expect for patients receiving standard of care of chemotherapy. When we look at the Napoli 1 trial, which randomized patients to nenoliposomal irinotecan and 5-fluorouracil versus single-agent chemotherapy, the intervention arm had a median survival of around 6 months. So basically the same as the control in the study. And that's the most contemporary second-line randomized trial that I'm aware of. So it definitely does work. Seems to be a appropriately run study. Questions moving forward will be, can it be as beneficial in earlier line settings, whether that's curative or first-line metastatic? And can it be safely combined with other treatments? Currently, there's an ongoing first-line trial combining this drug with gemcitabine and nab-paclitaxel versus chemotherapy alone. I would also be interested to see, as time moves forward, understanding whether or not dual blockage in the RAS pathway may be beneficial as well. In the case of colon cancer, we do not block BRAF alone, we block BRAF and EGFR. And in diseases like melanoma, we also block this pathway at 2 points. I'd also expect to see this drug begin to be studied in other disease sites and hopefully will be as beneficial, especially in lung cancer, for which many patients do harbor a G12C mutation or another KRAS mutation that may allow for additional treatment options in those settings. I anticipate that there will be ongoing studies looking at mechanisms of resistance and progression, and this will hopefully inform our ability to use this drug as efficaciously as possible. So there's some limitations to the study, namely the small number of patients that did not have a G12 mutation. I'm not sure whether or not we can extrapolate this extent of benefit to those patients. The high rate of dropout is less than ideal. However, as the primary endpoint was overall survival, it is likely that the investigators will be able to limit censorship in those patients, different than when progression-free survival is your primary endpoint, and losing patients to dropout limits our ability to analyze statistical significance if their patients are not following up for scans. Toxicity seems quite high with this drug, so we will need to see how well this translates outside of clinical trials into the general population when it comes to tolerance and acceptance. However, hopefully with addition of prophylactic medications, this will be manageable. We have never had a clinical trial in pancreas cancer where an intervention arm lives on average beyond a year. And although we all in practice know that some patients can derive long-term benefits from our chemotherapies, the average patients often are dealing with a highly morbid disease. So in the second-line setting for patients who've already received chemotherapy and progressed, the fact that this drug can provide a median overall survival of 12 months is something to be optimistic about. And I look forward to many more developments in the KRAS space now that we can safely say that it is not undruggable for the vast majority of patients with pancreas cancer. Once again, thank you for all of you who continue to listen. We look forward to being back soon with our final planned general discussion on glioblastoma multiforme in the weeks to come. Bye for now.
For more information, follow us on Twitter at Talking Tumors, or feel free to email us at talkingabouttumors@gmail.com.
Please rate and review the podcast. We really appreciate it.
And special shout out to our friend John Kim for all of his musical talents.
And he is the composer of the music that you're hearing right now. Talking About Tumors is not medical advice.
For medical advice, please contact your own healthcare provider.
The opinions stated on this podcast are by the Ryan who said it and no one else. We have no financial disclosures, and this is done purely on our own time to the sake of our enjoyment of the field of medical oncology. Thank you for listening, and see you next time.